Good evening. My name is Ashley Robertson from RBC Consultants. Welcome to another International Dermatology Education Foundation educational series. This evening, we have two very interesting presentations. The first presentation is with Dr. Leon Kircik. Dr. Kircik is president of the International Dermatology Education Foundation, clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai, New York, and Indiana University Medical Center in Indianapolis, Indiana, and medical director of physician skincare, derm research, and skin sciences, located in Louisville, Kentucky. Dr. Kircik will be presenting Red Faces, a discussion on a new treatment paradigm for rosacea with an emphasis on red faces. This presentation will be followed by Dr. Joshua Zeichner, who is Associate Professor of Dermatology, Director of Cosmetic and Clinical Research, Department of Dermatology at Mount Sinai Hospital in New York, New York. Dr. Zeichner will be presenting about understanding the evaluation and management of persistent facial erythema in adults with rosacea. We would like to thank our supporter tonight, EPI Health. They have made this educational event possible. Before we begin, a few logistical topics. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, or if you would like to submit a question to our faculty, please submit your questions in the question pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill in this very short survey. And also within 1 to 2 days, you will receive a certificate of attendance. This will be emailed to you. Without further ado, I would like to pass the floor virtually to Dr. Kircik.
Thank you, Ashley, and good evening, everyone. Welcome to another monthly traditional series of IDEF educational series. So I'm really excited tonight to co-host with Dr. Josh Zeichner, who's a good friend of mine from Mount Sinai in New York City, and we will discuss overall about facial erythema, red faces, mostly related to rosacea. So I'll start with, if I can move, this is my, so rosacea, it really has become a very interesting topic lately in dermatology in the sense that our understanding of the pathogenesis of rosacea has evolved. You know, we used to call it acne rosacea or adult acne. Now we know that it has absolutely nothing to do with acne or with adult acne. Yes, we see mostly females. Yes, mostly we see adults, but it is not acne. It's a whole different ballgame. It's a whole different pathophysiology, and the treatment should be, of course, different. This is my conflict of interest statement. I do a lot of clinical studies, therefore I do receive funding from several different pharmaceutical companies, including those that I will be mentioning their products tonight. So, ironically, rosacea may impact all different types of people, all different types of population, as you can see here, all the way from Santa Claus to famous actors to the ex-presidents. And sometimes it does impact with just a red face that we always thought, oh my God, it's a healthy face, right? This is a picture from Berlin Museum before the good old days when we did not have COVID. When I used to travel, I visited Berlin Museum, and it's ironically picture after portrait, you see people with red faces. And several years ago, of course, those red faces were actually as a sign of healthiness and health and wealth. And it's very interesting. Now we know that certainly that is really not the case. And certainly rosacea have a lot of negative social impact on our patients, all the way from inhibiting social life, not being able to go to work, not being able to establish new relationships. And those, you know, the numbers are all over the place, but regardless, we know those negative social impacts from our patients. Now, if we think about the old way of thinking and looking at rosacea, we always thought that there are 4 major types of rosacea. One is erythema telangiectatic rosacea, type 1. Type 2 is the popular pustular rosacea. Type 3 is rhinophyma. And type 4 is ocular rosacea that involves the eye. So those were 4 major subtypes. But when you think about these subtypes, really, and we see this every day in our offices, one patient doesn't just have one discrete type, right? Sometimes they come with the red face and they just have type 1. Sometimes they come papulopustular rosacea. The next month they show up with 3 or 4 of the above. You know, I have an ophthalmology group both upstairs and downstairs in my building, and they send me a lot of ocular rosacea. And when they come, sometimes they have both rhinophyma and ocular rosacea, or they have sometimes papulopustular rosacea, or sometimes they just have ocular rosacea. So this is type 1, and what you see is the central facial erythema that we are all accustomed to see with some telangiectasias, and you might have some periocular or perioral sparing, and certainly they have some flushing and blushing, but they don't have papules and pustules, which is the differentiating factor from what I call type 2 rosacea or papulopustular rosacea. But ironically, papulopustular rosacea patients, they certainly have perilesional erythema, and sometimes those papules, they confluent together, and that perilesional erythema become one, which might be difficult to differentiate from type 1 rosacea. Certainly they have telangiectasia, and they do have periocular and perioral pallor as well. Rhinophyma or phymatous rosacea, it's a unique type, and honestly, all these years, I have not seen a single female patient with rhinophyma. Some of you may have seen it, but I've seen mostly men. And certainly can affect the chin and the eyelids, and it does have a bad stigma that usually people think that people who drink end up with rhinophyma, but absolutely it's not true. Ocular rosacea, again, sometimes most of those patients, they go to the family practitioners or the eye doctor where they have some blepharitis, conjunctivitis. Certainly they get some eye drops, but they don't get better. So they end up at the dermatologist finally, especially if they have the skin symptoms. But as I mentioned earlier, I do have large ophthalmology groups in my building, both upstairs and downstairs, and I get a lot of their referrals. But this looks like, even the blepharitis, it might be a sign of ocular rosacea that we should remember, because you know it's mostly yellow, and we're talking about red faces, red eyes, but this is mostly yellow blepharitis, but it can be a sign of ocular rosacea. Now, when you put all these 4 subtypes together, and when you look at the percentages, right? For example, subtype 1 is the most commonly seen one, 64%, papulopustular rosacea 36%, rhinophyma is 24%, ocular rosacea 36%. But when you add those up, it adds up more than 100%. So now you're going to say, what's going on here? You messed up the math, Dr. Kircik. Well, I didn't, because what happens is that those things, you see them together, subtype 1, subtype 2, those are not separate things. Those are just symptoms that overlap of rosacea. So it's really not a good thing to separate those subtypes as subtype as if they are distinct entities. They are not. We see those things most of the time, those symptoms most of the time as overlapped, or sometimes you see 1 and 2 together. Next month the patient comes, you have 2 and 4, or 4 and 1. So the bottom line is, I think it's important to remember they are not well-defined, separate, distinct entities. They basically different symptoms, signs and symptoms of rosacea that sometimes overlap and sometimes they don't. Now, of all those things, facial redness, it's the most common, and it is the most important one because it bothers the patients the most. Now, that is type 1 diffuse central facial erythema, or what I call actually the background erythema that we see. It is different than the perilesional erythema. But as I mentioned earlier, the perilesional erythema sometimes can be so more diffuse, and there are so many lesions that perilesional erythema becomes confluent, and it looks like as a one large piece of erythema, which might be easy to confuse with type 1 background erythema, especially when both papulopustular rosacea and erythema telangiectatic rosacea, they coexist together. So back in 2017, National Rosacea Society, basically redefined and classified of rosacea. And as you can see here, that now we have major diagnostic factors, and you have to have at least 2 or more of those major diagnostic factors, and they include flushing, of course, papules and pustules, telangiectasia, and ocular manifestations. So as you can see, there are the secondary factors as well: burning, stinging sensations, certainly edema, dryness, and ocular manifestations are part of this. So when we look at the pathophysiology of rosacea, it's very interesting. So we need to think about from both perspectives. One is what causes the background erythema, type 1 telangiectatic, erythema telangiectatic rosacea, and then what causes the papules and pustules, the inflammatory process, and what is the cross overlapping, what is the cross section of those two, right? So I'm sure most of you have seen this slide where we sort of helps us to understand the pathophysiology of inflammatory papules and pustules. So we start with the human catalyst and precursor, and that is the activation of the kallikrein 5, which is serine protease activity enzyme. That enzyme basically breaks down the HCAP18 into several small peptides and one large peptide. The large peptide there is LL37, and it's called LL37 because it's a 37 amino acid peptide, and it starts with leucine and leucine. That's hence the LL part. LL37 is an inflammatory peptide. It basically causes chemotaxis. It does have some antibacterial, antiviral activity, and it's a part of our innate immune system, right? That's basically innate immune defense that is activated. And think about it just like the first line of defense when you go to the airport, right? The first thing you have to go through the security, the TSA, right? They check your luggage and baggage. So that's basically checking luggage and baggage for the body innate immune system. And in this case, it's activated, right? It's like red alarm. That's high terrorist activity. Just think about that. And also, though, it causes angiogenesis. Basically, angiogenesis is going to cause redness, right? Think about that. But the question is, what is causing here the high alarm? Some of those peptides are called alarmin, by the way, right? So what's causing that high alarm that we're activating kallikrein 5 in order to come up with the LL37 and the consequences? We don't know that. There are several different theories what triggers it, but what's causing it? A trigger is causing it, and that trigger can be, by the way, sun, hot tea, hot coffee, heat, hot showers. Maybe it's a mic, right? Demodex we have discussed. So we don't know, but once it's triggered, so that's basically the suspected terrorist activity that becomes the red alarm, right? Red alert at the airport. And then toll-like receptor number 2 is activated. And we know about toll-like receptor number 2, it's also active in acne, and that's activated by P. acnes. So in this case, something else is activating it that we don't know. But once it gets activated, that's where the kallikrein 5 is activated, and hence the breakdown of the HCAP18 and the LL37, and hence all the activities. So that's the sort of the pathophysiology of papular pustular rosacea, at least so far that's our understanding. I will not be surprised if it changes in 10 years. Yet, that doesn't explain the background erythema or erythema telangiectatic rosacea, right? So here's another one of those pictures, but we thought it was a health and wealth sign in 1600s, but now we know that they all had rosacea. So what is activating here? It's a neurovascular dysregulation. So basically, it's a neurogenic dysregulation that's causing vasodilatation. So it's a whole different ball game here. And the players are here, TRPV, which is it's a vanilloid-like receptor. And when you look under the electron microscopy, you see the dilated vessels, you see subpapillary plexus vasodilatation, and large and thickened vessel walls. it's really different than what you see in seborrheic dermatitis or normal skin, right? And the key here is vasodilatation. But what's causing the vasodilatation, right? What's causing vasodilatation? It's interesting. It's not the vessels. It's actually a neurogenic vasodilatation because there are a bunch of sensory nerves are very closely associated with the blood vessels. And these sensory nerves, upon stimulation, they actually secrete neuropeptides that induce vasodilatation. And that's what's happening here, the peptides that causes vasodilatation. And those are known as substance P, calcitonin gene-related peptides, but there is a receptor, and those receptors are also activated, and they are expressed on neuronal and non-neuronal tissues, and those are called TRPV1 and TRPA, and they are sensitive to actually spices. They are sensitive to very low temperature changes, and hence the patients with rosacea, they get red at small high temperatures or small temperature changes, right? Those are known as the transient receptor potential vanilloid receptor 1, and all these weird names, I have no idea where they're coming from, who named them, or why they named it that way. But if you biopsy a rosacea subject, you will see that they had elevated levels of TRPV1 mRNA, and hence the elevated activity. And they really are mediate responses to spicy food, the temperature changes, UV radiations, and other stimuli, and eventually they cause that vasodilatation. Now, the other thing that causes vasodilatation that we discussed is LL37, right? So again, you see this cooperation between the innate immune system and neurovascular dysregulation to create the redness. But ironically, so you inject LL37 into the animal model, they will get redness. But if the animal model is missing mast cells, then then even though you inject LL37 into the dermis, the mast cell deficient mouse model is not going to develop like rosacea-like features. And that's very interesting. So here we have another player in the pathogenesis of rosacea, which are the mast cells. And when you look at mast cells in rosacea patients' skin, they are also increased in numbers. So again, something else is going on here that we are not aware, and we haven't put it all together. But now we know those players: neurogenic dysregulation, neurovascular dysregulation. We have the innate immune system, and we have the mast cells that they are playing a role in all the pathogenesis of rosacea. Let's take a close look at what's happening at the vascular level. So this is the sympathetic nerve terminal, and as you know, the blood vessels, they have a inner smooth muscle, right, that causes the blood vessel constrict or dilate. Those smooth muscles also have receptors. Those are alpha receptors, alpha 1 and alpha 2. So inside that endothelium and the smooth muscle, you have the alpha 1 and alpha 2 receptors. Now, alpha 1 receptor is always expressed postsynaptically on the blood vessel side on the smooth muscle. Alpha 2 receptors are much more complicated, and they basically can be expressed at pre or postsynaptically, but they're also expressed on the endothelial cells. And that's where the problem is with the alpha 2 receptors and where the alpha 2 agonists are, because they may not only cause vasoconstriction, but they may cause vasodilatation. So that's a poorly understood receptor, and the agonist, of course, in this case, will play different roles in different conditions. Vasoconstriction is induced upon the activation of the postsynaptic receptors. Those are located on the smooth muscles, and the regular natural agonist here is, of course, norepinephrine. So therefore, not all alpha agonists are the same. Brimonidine that we had came to the market as our first alpha agonist for redness treatment or related to rosacea is mostly working through alpha 2 receptors, and then oxymetazoline, which is sort of the second comer to the market, primarily works through alpha 1 receptor. But remember, the problem with the brimonidine working through the alpha-2 receptors may also cause paradoxical vasodilatation, even though it does work for vasoconstriction, and because of those location of those receptors and how they react. So oxymetazoline is an alpha-1 adrenergic receptor agonist, and always because of our first earlier experience with the alpha-2 receptor with brimonidine, rebound has been scary, and we always worry about the rebound that we may end up with vasodilatation and the patients get worse, which it did happen in our experience, in the past experience with the alpha-2 receptor agonist, in this case with the brimonidine. So because of that, I was involved with both studies, by the way, but with the oxymetazoline study, the agency was much more strict, and they wanted to see if there is going to be rebound. And in this case, the rebound was defined as after stopping the treatment, we looked at the patients up to 57 days. So we stopped the treatment at 29 days, and we looked at the patients up to 57 days if they had any rebound. And again, remember the definition of rebound, the clear definition of rebound is what happens after stopping the treatment. So this was called post-treatment follow-up period that we had with oxymetazoline, and FDA really insisted upon this after the experience we had with the brimonidine. So as you may remember, there was clinical erythema assessment and also the subject assessment, and those were both asked and taken, and the rebound in this case was considered worsening of the erythema to grade 4, both assessed both by the subject as well as the clinician. And there were scheduled post-treatment visits, including days 4, 5, 6, and 7 following the cessation of the treatment, and then 4 weeks after the last dose. And also at any point, if the patients thought that they had worsening erythema, they were supposed to call us. At any time, they were allowed to call us for an unscheduled visit. And guess what? Nobody called. No patient had an unscheduled visit during the rebound evaluation, which is very, very interesting. So then you can say, but wait a second, oxymetazoline is afrin, and afrin causes rebound. We know that. Actually, there is people say don't overuse afrin because then you will end up with more stuffy nose, right? As a rebound effect. So what happens is they looked at that, and this was called rebound congestion and rhinitis medicamentosa. And why is it happening? So there was a huge medical panel. This was in France, I believe. And when they looked at this, they found out that in the vehicle of the afrin, there is a preservative called benzalkonium chloride. And it's actually not the oxymetazoline itself, but it is benzalkonium chloride causing the rebound effect in healthy volunteers. So when you look at the afrin package insert, you can see that there is benzalkonium chloride there, and that's causing the problem. Remember now, oxymetazoline hydrochloride is 1% cream. It does not have benzalkonium chloride in it, right? So again, Rofate in this case is not afrin. So it's very important, and I always say in dermatology, vehicle matters. And this is why sometimes the excipients of a drug is more than the main ingredients or the incipient. So now that brings us, always the question we had, how do we treat those patients who had both the background erythema and the popular pustular rosacea, right? So there were a lot of different theories when brimonidine came to the market first. Do we treat them both at the same time? Do we take care of both popular pustular rosacea and the redness? So do we do it an anti-inflammatory as well as the brimonidine? Or maybe not, we don't want to cause any irritation, we don't want to cause rebound erythema, maybe let the skin calm a little bit with the anti-inflammatory, and then we'll start the redness drug, right? A week, 2 weeks later. Or maybe we do one first, 2 separate times. So the bottom line is we did not have a good clinical experience or any study that lets us to somehow how to treat rosacea, both from the inflammatory perspective as well as the redness perspective. So Galderma, quite a couple of years ago, did design this study. It's called the Mosaic study, which is very interesting. And of course, they use their own drug, in this case, ivermectin 1%, which is the anti-inflammatory for papular pustular rosacea, and they use the brimonidine, right? And they had actually 3 arms. When you look at it, first arm is they started patient both on ivermectin and the brimonidine at the same time for 12 weeks. The other group did only ivermectin the first 4 weeks, and then they added the brimonidine for the next 8 weeks. And this was for the idea that maybe we should let the skin calm down with the ivermectin or any anti-inflammatory for that matter, and then add the alpha agonist. And then the third group was both the vehicle for ivermectin and the vehicle for brimonidine. And guess what happened? So what happened was basically the patient's overall, which is the IgA inflammatory, investigator global assessment, basically did overall rosacea did the best with the combination that started both medications at the same time. So that was group 1, the first group, okay? And there was statistical significance between that group and the second group, where they had the brimonidine started 4 weeks later. When you look at, but something also more important and more interesting happened. The people who had inflammatory lesion count in the first group that they started both ivermectin and brimonidine at the same time, their inflammatory lesion count did better too, which sort of it's difficult to explain because as far as we know, brimonidine does not have an anti-inflammatory effect. But guess what? Maybe it does. And when you put them together, maybe it did work well. So maybe the alpha agonist as well, they might have an anti-inflammatory effect. We really don't know that part. But why did this happen? It's interesting that it happened that inflammatory lesion count also did well in the group that started. Now, of course, that was a study that Galderma arranged it, and they used their own alpha agonist and they used their anti-inflammatory ivermectin. But the concept is here important. You can replace the brimonidine with oxymetazoline. You can replace the ivermectin with another anti-inflammatory that you use. Can be azelaic acid plus oxymetazoline, can be oxymetazoline plus metro, it can be ivermectin plus oxymetazoline. The point is not important exactly what brand you're using. The important part here that this is a teaching point for this study that you can use the anti-inflammatory as well as the anti-redness drug together at the same time, and we'll end up with better results. So that is the point of this study. You certainly can replace the brimonidine with oxymetazoline. You can certainly replace the ivermectin with another anti-inflammatory drug to take care of the papules and pustules. So I think that is the new teaching and new learning that we have some evidence-based studies and experience. So I thank you so much. I'm gonna stop here. If you have any questions, you can write to me at wedoderm@yahoo.com. I thank you so much for your attention, and I am right on time. I will pass the podium virtually to Dr. Josh Zeichner, who's a great friend of mine, a great dermatologist from Mount Sinai, and he's going to tell us about understanding the evaluation and the management of persistent facial erythema in adults with rosacea. Josh, thank you so much for joining to IDF panel here, and take it here. Thank you.
Great. Thanks so much, Leon. It is always hard to follow Leon Kircik because he's just such a great speaker. But and thank you so much to the organization for having me. I know I was introduced before, but for those of you who don't know me, I am a dermatologist on full-time faculty at Mount Sinai Hospital in New York City, and I'm very excited to be here taking you through this lecture. Let me take a look. Hopefully I have control. Okay, great. So as Leon said, the title of the talk is Understanding, Evaluation, and Management of Persistent Facial Erythema in Adults with Rosacea. Okay, and just thank you so much to EPI Health for their sponsorship today. And some of what I'm going to cover in the beginning overlaps a bit with what Leon just went over with you. But let's first talk about redness in general. So rosacea patients, by definition, suffer from facial erythema to some degree. And there's different types of erythema, as Leon just pointed out to us. So first of all, we have redness during an active flare. So we know that rosacea patients tend to flush and blush more easily than other people. And then that flushing and blushing occurs to a greater degree than we'd expect it to happen. So that's what we're talking about on the left. You're getting flushing and blushing and a greater degree of that flushing and blushing. Then over time, rosacea patients tend to develop some background redness that's persistent, even when there isn't actually a flare. So that's what we talk about when we refer to the persistent facial erythema, or some people refer to it as PFE. And then, of course, we have the perilesional redness, and Leon had a beautiful slide demonstrating that. But that is really different than the background redness. So I want you to picture a sea of redness with individual little areas where you have red bumps. And that's what we have in this picture on the right. You can see the individual papules and pustules of rosacea. Here's a patient with that type 2 papulopustular rosacea that Leon talked about. But again, still having some background redness. That's that red sea connecting the bumps. Okay, let me just see. How come I can't advance? Oh, there we go. Oh no, I advanced too much. So let's go back. My arrows work. There we go. So again, back in 2002, the initial categorization of rosacea was published as guidelines. And we originally had these 4 subtypes. The erythematotelangiectatic subtype, those are the flushers and blushers. The type 2, the papulopustular rosacea, those are the patients who have the bumps and the pus pimples. The type 3, those are the patients who are predominantly men and have the phymatous changes to the nose and the chin. And then type 4, which is the ocular rosacea, when you're getting redness of the eye itself and the skin around the eye, the blepharitis, and that gritty feeling in the eye, like there's a piece of sand that's stuck in the eyes. And we often have overlap among these different subtypes, so they're not mutually exclusive. Okay, let's see, am I advancing? Here we go. And as Leon pointed out, there has been a shift in the way that we're evaluating our rosacea patients. We're no longer putting them just into these buckets, 1, 2, 3, and 4. Instead, it's really better to evaluate patients based on their phenotype, looking at the clinical signs that they're actually exhibiting. And as you can see, in this table here, and Leon showed it directly from the paper itself, in order to be diagnosed with rosacea, you need to have 1 diagnostic phenotype, or you can have 2 of the major phenotypes. So you can be diagnosed with rosacea just by having that fixed background erythema, or by having phymatous changes. If you don't necessarily have significant background facial erythema, then 2 of the major phenotypes can give you the diagnosis. So you can have papules and pustules and flushing, or any of these different characteristics. But the secondary characteristics are in addition to one of these, 2 categories. So a different way of evaluating our patients based on what we know about the diseases. Okay, sorry. Here we go. I think it's a little slow on my end as we transition from slide to slide. Sorry about that, everybody. But when we treat rosacea, we really need to address the different pathogenic factors. I think this is really clear when we treat acne. And there are consensus guidelines saying that we treat acne best by combining different drugs with multiple mechanisms of action that address as many pathogenic factors as possible. But we need to think about rosacea as having 2 main pathogenic factors. Again, to repeat what Leon said, first of all, we have neurovascular dysregulation, and that's what leads to the flushing and the blushing, as well as burning or stinging in the skin. Then completely separate from that, we have the immune-mediated inflammation. So that's the overactivity of the innate immune system with overprocessing of antimicrobial peptides like cathelicidins, and that's what leads to the bumps and the pus pimples, ocular manifestations, and the perilesional erythema. So I think that when we write prescriptions for our rosacea patients, it's important to understand specifically what they're approved for. Know what's in their package insert, because if you know how a drug is supposed to be used, then you're going to use it the right way, and you'll be able to educate your patients the way you want them to be educated. Because you don't want to give a patient a medication that's specifically designed to address bumps and pus pimples, and then they come into the office and they still have a rosy face and they're upset. On the other hand, you don't want to give them a vasoconstrictor and then they still have bumps and pus pimples. Instead, we want to give them both. And that actually is an on-label indication, because if you look at the package inserts of these different drugs, what's really unique with the rosacea medications is that drugs are either approved to treat the persistent facial erythema of rosacea, or they're approved to treat the bumps and pus pimples, the inflammatory lesions of rosacea. So I personally combine these medications, which again is on label, and this is what we should be doing, because rather than just treating one disease as a whole, now what we can do is really think of the different components that make up that disease and give our patients medications that address each of those components. So this is what I was talking about a little bit before. The vascular dysregulation, or the effects of the vascular dysregulation, are cumulative over time. So we have blood vessels that, let's just say, get a little lazy, or they just dilate abnormally, and they don't constrict the way that they should. So over time, the blood vessel walls get thicker and thicker, and the vessels themselves get lazier and lazier. So you're initially starting out with intermittent erythema. Eventually, that persists, and you get persistent facial erythema, which may just be a rosy glow. Leon showed us all those great paintings that were in the museums. And then over time, that persistent facial erythema just gets more and more significant. And I definitely have patients who feel self-conscious about the way that they look. Many people feel that the facial erythema is associated with a negative stigma. I have had patients come in saying that they've been asked if they're an alcoholic. I've had patients ask, what's wrong with their face? Do they have a disease? So I think it really depends on the particular patient and on the severity of the redness. There are some people who are not bothered by it, some people who are significantly bothered by it. So I think as dermatologists, when these patients come into the office, we need to ask them their face. And I think you have to be really careful about this, because you don't insinuate that there's actually something wrong with them. I like to ask the question in a way that gives the patient an out, because maybe the patient is bothered by it and he or she is not mentioning it, or maybe they don't even care. So I tend to put it in a finite context. I noticed today your face looks a little bit rosy. Is that bothersome to you? Does this happen often? And some patients will say, you know what, this is an issue. And other people will just, say it's not a problem whatsoever. But I think you always need to give the patient an out, because you don't want to imply that there's something wrong with them if they are not bothered by it. And again, that's just my way of approaching the patient. Okay. Now let's change gears a little bit, and we're going to talk a little bit about RHOFADE, which, as Leon mentioned, is oxymetazoline cream 1%. And this drug is indicated for once daily application for the facial erythema associated with rosacea in adults, and adults being 18 years of age or older. And here's the package insert. And this is a really busy slide, but you need to know what's in here for many reasons. Number one, you need to pick and choose the right patients who are appropriate for the drug. And number two, you need to educate your patients on potential adverse events. And the more you can educate your patients up front, the fewer phone calls that you will get to the office later. And that is all of our goals. It certainly is mine, to make sure that we are minimizing the number of phone calls that come into the office. So we talked about the indication. In terms of warnings, first of all, a warning in someone who has unstable cardiovascular system and kind of unregulated high blood pressure. So peripherally, alpha agonists are vasoconstrictors, but centrally they actually act as vasodilators. So for somebody who just has unstable or uncontrolled hypertension, orthostatic hypotension, we just have to be weary or cautious, I should say, about prescribing these medications. But these are really unstable patients, and they're not the typical patients that may be visiting you in the office. We have to be careful about prescribing these medications to patients who have vascular insufficiency syndrome. So, for example, someone who has Raynaud's, there is overconstriction of the blood vessels peripherally when they come in contact with cold temperatures. So putting a vasoconstrictor on the skin theoretically can make this worse, so you have to be careful. There also is a warning on the use of alpha agonists such as Rofade in patients who have closed angle glaucoma. There are no specific contraindications to using the drug, and the most common adverse events that occurred in the clinical trials was application site dermatitis. And we'll go through all that specific data. Here's the mechanism of action, very similar to the cartoon that Leon previously showed you. So Rofade is an alpha-1 adrenoreceptor agonist, and the alpha-1 receptor is located postsynaptically, so on the vascular smooth wall. The vascular wall smooth muscle. So binding to that alpha-1 agonist will cause constriction of that muscle, constrict the blood vessel itself. It's like making the pipe look smaller, as you can see on the picture on the right. And Leon also showed you that there's an alpha-2 subtype of the receptor, and that is located both presynaptically and postsynaptically. So an alpha-1 receptor agonist works differently than an alpha-2 receptor agonist. So it's a for another. But again, the Rofade binds to the alpha-1, which is located only postsynaptically. Hold on, why am I not advancing? There we go. So now let's move on to the phase 3 clinical trials. As you may know, any new drug coming to the market needs to go through a phase 3 clinical trial program. Oh, there it is. Sorry, guys. To evaluate the active drug compared to its vehicle, or in the case of an injectable medication or an oral medication, we're talking about a placebo. But when it comes to a topical, it is a vehicle, and the vehicle itself has an effect on the skin. Anything that we use on the skin, whether it's a cleanser or a moisturizer or the vehicle of a drug, can play some sort of role in the health or disease state of the skin. So there were 2 identical randomized vehicle-controlled clinical trials, as we have with all phase 3 studies performed by different investigators in different parts of the country. And the objective was to show that the active drug performed statistically superior compared to the vehicle. And this is standard for phase 3 studies. And the primary outcomes in phase 3 studies don't necessarily represent the way we evaluate an effective treatment in clinical practice. We're just showing that active drug is better than vehicle. We're not looking at absolute numbers. We're just looking for statistical superiority. So almost 900 patients, at least 18 years of age, were enrolled to the study, and we'll go through the endpoints now, if my slide will ever change. I'm clicking it. There we go. Okay, so here was the clinical trial design for the initial phase 3 study. So patients were randomized 1-to-1 either to receive the active drug or the vehicle, and then they were followed up at day 15 and then day 29. And then, as Leon said, there was a post-treatment evaluation period up to day 57. And to my knowledge, and I think Leon mentioned this, there were no unscheduled visits to the office in that post-treatment follow-up, and that was there for evaluation of safety or significant worsening of redness after discontinuing the drug. And the efficacy of the drug was evaluated before the dose was given, at hours 3, 6, 9, and 12 when the patients came back to the clinical trial center, and the primary endpoint was at day 29. So let me take you through that. It's going, I think. There we go. I see it slowly advancing. Oh, I think I went 2 slides. Oh no, sorry guys. You'll just have to look at my smiling face as I'm talking this through. Hold on, hold on. Okay, so there's our slide. Now here's our point. So the primary endpoint in this study was a really high bar, and it was difficult to achieve. So the primary endpoint was a composite score. So as you can see in this Venn diagram, there were 2 assessments. So first, the patients evaluated themselves. So that's the SSA, the subject self-assessment. Then totally separate, the investigator or the physician evaluated the erythema of the patients. That's the CEA, or the clinician erythema assessment. And in order to be considered a treatment success at day 29 at any of those time points, both the clinician and the patient both had to agree that there was at least a 2-grade improvement in background facial erythema. And this was a static assessment. So that means that nobody was able to go back and take a look to see how they previously evaluated themselves. So this is a really high bar and a difficult endpoint to achieve. And here's the data. Hold on for a sec. Let's go through this. Okay, so here is a table just summarizing the efficacy data, the treatment success in trial 1 on the left, and then on trial 2 on the right. And we're looking on day 29 at each time point. You can see, hopefully you guys can see my cursor. I think you can. So here, starting out at hour 3, then hour 6, 9, and 12. And all I want you to pay attention to in this particular slide are the asterisks, okay? Oh my goodness. We'll see if it goes back. I'm trying to go back here, but there we go. The asterisks show that there is statistical superiority in the percentage of patients who had at least a 2-grade improvement in that composite score, saying that both the clinician and the subject both agreed that there was at least a 2-grade improvement in redness in that static assessment. So I don't want you guys to look at these numbers and say, oh, it only works in 13% of patients. That's not what this is saying. This is just saying that only 13% of patients or 16% of patients achieve that primary endpoint, which, as I told you before, was a really, really high bar pre-specified by the FDA and doesn't necessarily mimic the way we would evaluate a happy patient in the real world. But the drug did what it was supposed to do, and it was clinically superior to the vehicle. And that is the point of a phase 3 study. So I think a photo is worth 1,000 words. And when you see photos from pharmaceutical companies, know that they're not the best photos. There actually are regulations on what photos companies are able to show physicians or consumers, and they have to be average photos. So here on the left, you can see pre-dose on day 1, significant erythema. And now we have that primary endpoint. So photos at hour 3, 6, 9, and 12 on day 29. Now, as we look at these pictures, you can see the patient looks a lot better than she did on day 1 pre-dose. And actually, as you look at the pictures objectively, side to side, I don't really see much of a difference in the facial redness. But remember, this is not the way that the trial was performed. The patients and the investigators had to grade each, themselves, and they assess you that exactly the same. And we had the luxury of looking at the 4 pictures side by side. Only 2 of them were considered a treatment success. And I think we have a build here. Let's see. Where's my build? There we go. So take a look at this. I don't know what you guys were thinking. Hour 6 and at hour 12, this particular patient was not included in that in the percentage of patients who were considered a treatment success. So when you look at the numbers before and you see numbers only in the teens, Now you understand why those numbers aren't higher. Because if we were just evaluating the patient here, I probably would have said the patient was a treatment success at all time points. But again, only considered a treatment success at hour 3 and hour 9 in the clinical trial. And let's take a look at another set of photos, if my slide will ever come up. Oh, there we go. It's really slow. I see it transitioning on my end. There we go. So here's another individual who I think is a female. I apologize. Oh, shoot, and I hit it twice, so I ruined my whole thing. Anyway, the point here is that you can see that day 1, pre-dose, the numbers are here. The patient has, moderate or severe erythema. And then as you can see, as the 4 photos are put together, the patient looks just about the same, across all 3. But there is great variability in the assessments. So the patient was not considered a treatment success at any of these times. So the patient looks a lot better from baseline. So in clinical practice, happy patient, but in the clinical trial, not considered a treatment success. Okay, I'm only hitting it once, and I'm waiting for it to go. There we go. I see my transition. In terms of adverse events, as I mentioned earlier, the drug was very, very well tolerated, and these are the most common adverse events that occur at least one throughout the 4 weeks of the phase 3 studies, and this is pooled data across both studies. So we're looking at application site dermatitis, worsening of inflammatory lesions, pruritus, erythema, or pain. It's not true pain, it's more of a disagreeable skin sensation. But you can see these numbers are very, very low. And patients, a very small percentage of patients discontinued from the study from any treatment emergent adverse events. And we're looking at, a less than 4% attrition rate. So that means that less than 4% of patients discontinued from the study, throughout that 4-week period. So that's a great number. Patients are very motivated to treat facial erythema, so they want to stay in the study. Okay, let's see. Is it going? Oh, here we go. So the paired phase 3 study, all drugs need to go through a long-term safety study. So this is a 52-week study looking at the development of adverse events that occur with continued use of the drug over that 52-week period. And here's the study for oxymetazoline, or for Rofade. If my slide will advance, there we go. So as I said, multi-center, open label, so everybody got drug for 52 weeks. And to evaluate the long-term safety and efficacy of patients with continuous use over 52 weeks. So 440 patients at least 18 years of age were enrolled into the study. And again, these are patients who had facial erythema, they couldn't have too many papules or pustules or nodules, or they would not have been considered eligible for the study, because again, specifically looking at persistent facial erythema of rosacea rather than those with papules and pustules. Okay, here we go. So this is the same type of data that we looked at before in the phase 3 studies, the pivotal. We have the same endpoint. So again, composite score of clinician and subject assessing erythema at each of these time points at hour 3 and hour 6 throughout the course of the study. And you need to have agreement. So remember that Venn diagram, both the patient and the clinician had to believe in static assessments without being able to look back in time that there was at least a 2-grade improvement. So what I want you to see here is that with continued use of the drug, you're actually seeing this trend. You're seeing an increase in the percentage of patients who are hitting this endpoint, and you're seeing much higher numbers at week 52 compared to day 1. And if you look at that kind of dark purple line, I think that this mouse is working. So take a look at this at week 52, pre-dose. So this is patients came back to the office. 11% of the patients actually thought there was at least a 2-grade improvement, and the clinicians agreed. And you're seeing even, at hour 6, you're having an increase in the percentage of patients who are achieving those primary endpoints. So while the drug is supposed to be dosed once daily, perhaps there is some sort of longevity or durability of the effect beyond that one day, because patients appear to be doing better, or I should say a larger percentage of patients appear to be doing better with continuous use of the drug. And this really makes us think about episodic use of the drug versus periodic or versus continuous use of the drug. So the drug is approved for continuous use, but I think a lot of patients think, oh, they can just use it when they get a little rosy or when they need it. But when we see that continuous use is giving better and better numbers, in my mind at least, that supports the notion of applying it daily with continuous use over time. And I think that, just like we saw before in the pivotal, here is a set of photos of a representative subject in the 52-week study. And here on the left, you can see day 1, pre-dose, significant redness. And here he is pre-dose at week 50 of the study. And to my eye, I personally don't see any erythema. So this is somebody that probably fell into that 11% of patients who had that treatment success even before applying the drug at week 52. And then you can see all the photos at every time point on the left, but they're a little bit small. It may be difficult to see. So here we're looking at treatment-related adverse events by quarter. So quarter 1, months 1 to 3, then 3 to 6, 7, 8, 9, then 10 months 10, 11, and 12. And what I want you to pay attention to here is that you're actually getting fewer side effects with continued use of the drug. I think that sometimes when people put medications on, they're a little anxious or excited, or perhaps they over-report some potential adverse events. So you can see the greatest number of adverse events occurring in the first quarter, and that tends to calm down with continued use. And the other thing that number of adverse events. So it's not like when you keep using the drug, it's giving you more side effects. So you're actually seeing the opposite of that. So that is very reassuring as we recommend our patients use this for extended periods of time. And let's see, I press my button. Here it goes on my end. Perfect. So the drug should be used once. The current recommendation is to use a green pea-sized amount applied to a thin layer. I tend to recommend the connect the dots method. I'm sure many of you have heard of this. Green pea on the finger, then spread the green pea, dot, 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 rub it in, connect the dots. If you try to apply it all to one area and then spread it from there, it takes more medication to cover the entire face. You want to apply the product only to clean skin, and no open or raw skin. Make sure that you wash your hands immediately after application. It's used for the face only, not for oral ophthalmic or intravaginal use. And of course, you always want to warn your patients to avoid any potential triggers for worsening of redness. And these include, as I'm sure you know, spicy foods, hot beverages, alcohol in general, extreme in temperature, and emotional stress. So everything that happens in life and everything that's going on in COVID actually, can be a trigger to rosacea. And actually, talking about COVID, I personally am finding that the face masks are a huge trigger for rosacea and rosacea variants like perioral dermatitis. There is direct friction of the mask against the skin. The mask is trapping exhaled breath and increasing humidity of the skin. So it's kind of like this part of your face is living in the tropics, and this part of your face is living in your natural environment. So the two parts of the face are exposed to different environments, and I think that probably is contributing to the worsening of rosacea. And I definitely am seeing significant worsening in background erythema as a result of the mask. Oh, and I think that was my last slide. So Leon, hopefully I stayed right on track for you as well.
You certainly did, Josh. So we're right on 8:05 p.m. So we are right on time. I thank you very much for that great lecture. And if you guys have any questions, please submit your questions to info@idfeducationalseries.com. And I'd like to thank one more time to EPI Health to make this to support us and to make this program available to us. So I thank you very much again, and have a good night, everyone. Josh, thank you so much. Bye bye. We'll see you next month in another series.